John, if you're my child, he's one of our favorite children. Paul has a wife. She's also one of our favorite children. Why do I say that? We're all family.
Oh, what a nice lady.
Congratulate you.
Down there.
Down. So John asked me to talk about the impact of the ACA, or the Affordable Care Act, on the Inland Empire, and I'm happy to do it. And there are many impacts, I think, that we could foresee that I didn't put down here, so if you want to talk about them, we will. So where are we now? You all know that the main aim of the ACA, at least I think you know, was to reduce the number of people who were uninsured. People like to call the ACA Obamacare, so I put it in here. 7.1 or now up to 7.5 million people have signed up so far. And of those, 1.2 million came from California, and they enrolled through Covered California, which is our state exchange. And along with the one in New York, it's the one that's thought to be the best and most operational. Now, you may have heard of all the problems at the beginning of all of this. It was on the front page of every newspaper, including the Inland Bulletin and everything else. Let me ask you a question. What people ask me, well, what do you think? I would have said, if you don't have problems at the beginning, it would have been miraculous. Absolutely miraculous. This is the most important social program, if you will, that we've put in, or public-private program that we've put in since Medicare, which is about to be 50 next year. Unfortunately, I'm older than that. But those problems have shaken down, and we're now at the point where over 72,000 Inland Empire residents were enrolled in Covered California between when it started in October and in February. And that number is up, I'm sure, because we just closed yesterday enrollment in Covered California for the year. I have no idea how many more people, but it's certainly more. Something impressive. Remember, the ACA was supposed to reduce the number of people who are uninsured. In 2013, that fraction of our population was 17.6, though we know in this region it was higher than that. As of today's Los Angeles Times, I didn't get to see the original Gallup data, but Gallup is reporting through its latest survey that that fraction is now down to 12.9%. That is a much bigger drop than any of us would have expected. And it is estimated that in this country, 12 million individuals who are uninsured gained coverage through the exchanges. We know that's now 7.5 million of the 12. But the rest through, that's a typo, Medi-Cal, Medicaid, and private insurance. As you will know, or as you might know, these exchanges are all over the place. In the blue, you have the state, the light blue, the baby blue, you have the state-run exchanges, like California and like New York. The ones in blue were the federally funded and run marketplaces that you read about on the front page of the paper most of the time. Part of it, and part of a large jump, but I can't tell you what fraction in California yet because there aren't good data. A large fraction of that jump came from the fact that you'll see California in that medium shade of green. There were states that expanded their Medicaid program. In this state, of course, it's Medi-Cal. They expanded the program above the poverty line to about 140% of the poverty line, which means that a lot of people who were uninsured before are insured under Medicaid that weren't before. And remember, there is a mandate on employers. We also don't have good data of what exact fraction of that new 12 million are covered because their employers provided it to them. But that's also another story. Provide it or pay a tax. Now, one of the things that really didn't happen yet is there was supposed to be an exchange for small businesses, a place where employers who had less than 50 people could send their employees to buy health insurance with their help, okay? Not the regular exchanges, but something for small business. That didn't get going. That was a failure at the beginning of this year. And so that's all been put off till 2015, but small businesses can still claim tax breaks for insuring their employees. So this is another thing to watch happen over time. Will these shop exchanges be popular, and will it change the nature of the health insurance market, which it very well may. But soon I'm going to tell you about something else called private exchanges that I think may change it even more. Now, what to look for in the future? This is where private exchanges and a bunch of things come in. I call this more acceptance or a revolt. What I mean is, I'm going to explain to you what a private exchange is. Are people going to accept this type of change in how they get their health insurance covered while they're employed? Or are they going to revolt and say, I hate this, I hate this, I hate this? Now, let me exchange. Two good examples are Walgreens and Sears. And they're in the Aon Hewitt exchange. And here's the theory. Instead of paying a certain fraction of the premium for a family of 2 or 4, for example, you give a fixed amount of money to your employee and you say, go to the Aon Hewitt exchange and you spend that money however you want. Now, this idea is not very different than the original idea of having a voucher for schools or something like that. In fact, this idea has been around since 1982 and was proffered by a good friend of mine who's now an emeritus professor at Stanford Business School named Alan Enthoven in 1982. But the theory behind it is that you will go, and let's say there are 4 choices, and your employer gives you $10,000 to spend, and the premiums on some are $11,000 and some are $15,000, let's say. And that, by the way, you're sheltered from most of that, but that's not an ungodly number. That's about what we spend now. The whole idea is I'm going to shop around. If I think my health care needs can be satisfied in the $10,000 plan, then I'm going to have to trade that off against spending no more money or $1,000 more versus $5,000 more. And people believe that they'll make more intelligent choices, and if the lesser cost health insurance plans are there because they're run more efficiently, then health care costs will go down. It's a big bet. We don't know what's going to happen. It's separate from the federal system. This is a private system for private insurers. So the question is, for employers. So the question is, are employers going to do this more and more? Or are they going to stay the way it is, where if you're really large, you're a Walmart, you self-insure? If you're like Claremont, we have about 3,500 employees. We don't. We could, but we don't self-insure. We lay off the risk on the insurers we buy it from, and then we offer choices to our employees a different way. What happens in the private exchanges is it allows you to bulk purchase, if you will, private health insurance, right? So that you are spreading the risks over more people, and the whole idea is rates will come down also, not only because of more efficiently providing insurance, but how you provide it. So I don't know what's going to happen. Will it be accepted or will people revolt? We had a revolt in the country against managed care back in the mid-90s. Those of you in California might not remember it because Kaiser has been such an important part of the market here. Do I have a time problem? No, Kaiser's been such an important part of the market here that people accept managed care, but not other parts in the country, and that went down the tube. So I don't know what's going to happen. Acceptance or revolt, this is happening now. How many of you know what narrow networks are? Raise your hand. You will see this in your own private insurance if you're covered that way. If you've gone into the exchange, you will see it in almost every level, particularly the bronze and gold levels. This is where you can't go to any doctor you want. Only to these doctors and only to those in network. But there's a big difference between in-network and a narrow network. The in-network plans are pretty liberal about who they let in. So long as those doctors sign the contracts, they're in. And they will then accept reimbursement. These health insurers keep you out depending on your pricing profile. And the question is, if your doctor is not in there, what do you do? It's caused huge confusion, but what will it do? Now, another impact is the market is really changing, not only in health insurance, but how it's provided. Hospitals are struggling because the name of the game is to get people out of hospitals and join forces with physician groups to have an experience that's a lot more like Kaiser. Are we going to see hospital closures? We might. So that's going to be a negative effect unless everybody else has picked up outpatient. Greater emphasis on quality. We're going to start paying for quality rather than quantity. Right now with the fee-for-service system, anytime I go to the doctor, it's paid. There's an incentive to use more. If you reward quality, it's what happens to me that counts. Finally, where are costs going? I got news for you. The rate of growth of healthcare costs has slowed in the last couple of years. I think it's going to take off upward sharply. Why? We have so many more people who are insured, and we don't have enough providers to see them. And what we know is when people are insured, they use more care, period. And that means higher cost. So impacts on the Inland Empire, we're going to see increased costs, I think, decreased access because we need more nurses, more doctors, and more health professionals. And we need UCR and every other place probably to start a medical school, but there isn't the money to do it. UCR could probably quadruple its class, and those doctors would all have a place to go if they stayed, which they don't. Part of their strategy is they'll stay. But you can't increase the size of your class that fast. If that happens, the multiplier effect will be huge. Because if employment really goes up even faster than John is talking about, those people are going to go to Jack Brown's local Stater Brothers. They're going to buy more groceries. More people are going to be employed. They're going to go to Macy's or do more e-commerce, and all that business is going to come here. So how is it going to shake out? I don't know. Finally, my last slide. There are going to be cuts in Medicare and Medicaid reimbursements. I won't go over all of this. One of them is to disproportionate share hospitals. Those are the hospitals that see a very, very large fraction of Medi-Cal patients, places like Arrowhead. And they're places that also are teaching hospitals. In order to finance the ACA, one of the ways that was done is by cutting these types of reimbursements. There also is a threat of cutting Medicare Advantage plans. So the IEHP might be hurt if that happens. How that's going to trade off, I don't know. But just at the time when we may need to increase capacity, we may have hospitals struggling even more to survive. How's it going to come out? I'll tell you next year. Thank you.
Thank you very much.